They're coming to get our jobs. All the pharmacists prescribing medications, the PAs, the NPs, the AI. What will the doctor of the future look like? Well, I think I know what the doctor of the future will look like. At the end of this video, I actually want you to meet him. Also, for the last year or so, I thought I've been building a channel about medical office efficiency. Now I realize I was wrong. I'll tell you later how wrong I was and where. So if you look at this in detail, there's the other jobs slowly taking over what used to be the doctor's territory. It's like this creep up. As I said, pharmacists prescribing meds, PAs are now being not an assistant, but independent providers. So they're not an assistant anymore. They even bypass their name. The NPs can prescribe narcotics and order anything they want. Everybody gets independent. Everybody bites the piece of the cake that used to belong to us. And now, if you look at medical forums, there's a lot of people who are upset about it. A lot of doctors who say, this is not right. This is our territory. They want to defend it, right? That makes sense. I know a doctor who actually works urgent care only, and he recently told me, honestly, right now, what am I going to do? Because what I was doing in my urgent care was prescribing medication for UTIs and colds, and now it's taken away from me. I don't have a job anymore, or at least a lot of my job has been taken away from me. And I think that this is that future that's coming. The future of how things will be changing and what directions things will be going, because we can't stay frozen. And I think that the frozen identity comes from the identity of the institutions that have that identity in the first place. If you look how fast the world is moving right now, to build a startup, it takes a day. The AI will build you the website, the logo, the Facebook ad campaign. 6 months ago, the same thing took weeks or months. So the time compressed so much, while in the medical world, the medical education still takes years of pre-med, 4 to 6 years in some countries of medical education, then residency. Sometimes it's 10 years. And no one even thought of the fact that this could be made differently. So there is no desire to even think of a change there. There's a lot of business that profits from the fact that the medical education is 10 years. All the tuitions, institutions, all the departments, all the things frozen in time from about 50 years ago. And it's nobody's interest to cut it short. And now I believe that the same thing translates into a medical office, how we do our job. What's the systems we use in the outpatient medicine, in the office? We typically copy our teachers' models that are models from many years ago, and no one even considers doing delegation, creating systems, making sure we work easier and we only do what we absolutely have to do. So I started to believe that outpatient medicine and family medicine specifically isn't a uniform one thing. I think it consists of 3 parts. Number 1 part is the management. So how to organize your office, how to hire people, how to pay taxes, how to hire a bookkeeper, how to pay for your telephone bill. Number 2 would be the medical decision making, which is something we actually went to medical school for. The knowledge we read from books, the decision making, the thing that actually isn't the majority of it. It's probably the minority of it. And number 3 part is what I call the human connection. And I believe it's about 80% of all this, where patients come to talk to the doctor about something. They need a human. That's the job of a counselor or a job of a social worker that we are doing as family doctors, but it will be way better if there was someone specifically dedicated to do that rather than this being done by a rushed family doctor. Now, and since I realized there's separate categories of the outpatient family doctor's work, I started delegating the parts that I didn't think were crucial for the doctor to do directly. So when you walk to my office right here, you're gonna see my nurses doing all the vitals, taking the initial history, sending labs. And also what they do is they actually refill prescriptions. And the question is some doctors will even ask me, is it even legal? How can you delegate prescription refills to a nurse? That's not right. But actually, here's the thing. In the College of Physicians and Surgeons in Ontario, there's a specific policy about delegating prescription refills. And if you read about this in detail, it's possible. And often, we just don't even know about it. We don't even know about the tools we have. Now, a lot of doctors are familiar with AI because they use AI for their daily dictation. I have to admit that I tried AI dictation, but it didn't work for me because how I'm organized with the rooming staff. But a lot of times I use it for other reasons. I said that the AI is pushing doctors away, and I believe that it may even push doctors away from the counseling. Because what works for me, I'm not saying that anybody should be doing it like that. What works for me, I use AI for my own personal doubts, questions, for my own negative feelings, how to reframe reality, how to build a better next day for myself. So all I can say, it does work for me in the role of counselor, and I don't see anything wrong with doing this if you're comfortable with it. So yes, the way I organize my office is I am actually giving out all my work, or a lot of my work, to my support staff. I believe that AI can take care of a lot of work in the future. I don't know when it's going to be, but to some extent for sure, this will be taking over more and more. And to the point where I actually have to be honest with you, often I come back to work and I'm asking myself a question, am I even needed here? What am I being paid for? But here's the story that changes my perspective. So this week there was a patient who came into one of our rooms, not speaking very good English, and my students examined him. There was a urinary incontinence and abdominal pain. The patient was given pregabalin on the weekend for the pain, and then the students were wondering, is pregabalin causing urinary incontinence? How do we switch it for something else? It took me a second to look at the patient and walk in the door to realize that this was overflow incontinence. We did quick scan of the patient's bladder and kidneys. It turned out that one kidney was missing. He wasn't even aware about it, and the other kidney was getting slightly to moderately hydronephrotic. We put Foley catheter in this bladder, and we probably saved his kidney, if not his life, and saved the medical system a lot of thousands of dollars. Now, this proves that the clinical judgment is still of value. Those days are those days that make me think we're not completely obsolete yet. We have a level of knowledge and experience that can still come in the game and prove useful. I don't think AI or anybody replacing us will replace that part. So fair, if I'm arguing that a lot of things in family medicine can be done by protocols and by delegation, and me not seeing or seeing patients really briefly, how do I tell apart between the patient who needs me to see him directly and how do I decide who doesn't? And that's a fair question. And I don't know all the answers, but my suspicion is that the best idea is to have a lot of protocols. And if something doesn't completely match, then this should be brought to your attention. Just like with this patient who came with lower abdominal pain and pregabalin wasn't working. That would be something that the protocol should catch and bump it up to a higher decision maker. The second thing I believe is a useful thing here would be having availability. If your staff, if the delegation, if the protocols happen to not be working, that patient should have an ability to come back the next day to see you that something didn't work. Now, how do you have availability the next day? Because average family medicine visit in the States is about 30 to 40 days away. I don't know the Canadian statistics, but it's probably not better, and I would argue that it's probably worse. How do you make it work? And first of all, I think the big thing is the mindset change into cutting the things from your plate that you don't need and practicing medicine that isn't defensive. It doesn't require us to do a review of systems to check 12 checkpoints, and doesn't require to meet the insurance criteria as a first thing. And all those are creating, I believe, this backlog of 30, 40 and more days where the patient, if something didn't work, even when you treated the patient, they have no way to contact you until they have to go to ER. So yes, the very severe cases requiring good judgment are there, and I am confident that there is a good way to separate them from the ocean of the trivial cases in the day. And if I look at it, how I designed this for myself, I thought I was actually doing medical office efficiency. I thought I was doing tips for doctors on how to work better. But I realized that what I've been doing all this time is I was unbundling. Those three pieces of medicine, the management, the things that you absolutely have to do against the things you can absolutely delegate. And that is how it's been working for me in my office. That is why I'm able to be more efficient than everybody else, because I realized that there is this necessity to set it apart and delegate whatever you don't have to do. And for me, it didn't start as a vision. It started as a necessity. It started out of being frustrated with practicing the way I didn't want to practice. I practiced in many different countries, many different ways, and they all had the same thing in common. Doctors drowning in work that should never belong to them. So I built it differently for me. I started delegating. I have right now 3 secretaries and 3 nurses. My secretaries' numbers are split between 2 locations, so it's 3 or 4 of them. That allows me to practice 35 hours a week, taking care of 4,000 patients, going back at 4:30 home every day, and actually recently working 2 half days instead of 2 full days. So let's look at that capacity that had been freed for myself from the standpoint of maybe a system. If everybody was able to work this way, how much availability would there be for the patients? How much healthcare problems would there be fixed? As I said, I only work 35 hours a week, and in the past, I worked 100. So now, if I was able to work like I used to work, and it wasn't a big issue, 100 hours a week, I would be able to take care of myself of 12,000 patients. That is a number that's unheard of. Now, this is the part that I wanted you to wait for. Who is the doctor of the future? And I have to say, at the beginning, I thought that the reveal should say that the doctor of the future is me. But after thinking about it, the doctor of the future isn't me, it's the mindset that drives me to think how to delegate, how to separate my work, it's how to make sure that only what belongs to me lands on my plate. So I guess the answer is, don't defend your position. Don't wish for the past years of good medicine to come back, for the good old salaries to come back. The answer is to creep up, just like everybody else. Increase your value. Be more efficient. Take care of the 10 to 20,000 patients panel at one point with good support. It's not impossible. And having that mindset and that movement upwards, the self creep up, if you will, makes me not worried about our future. No one's gonna take away that judgment. No one's gonna come in and diagnose that patient with acute urinary retention by eyeballing him for 2 seconds. That's something that no one can take away from us, and we have to do this more. Don't compete with other specialties taking care of UTIs. Go up higher and make yourself the ultimate specialist in your field. So yes, I think the future will surprise us. Think with me, disagree with me, like this video, put some comments on there, and I see you next time. Take care of yourself first.